everybody, welcome to another episode of the OIG Roundtable. Today, again, we're at OIG Coffee Table. Matt Kachansky took PTO. I didn't approve it. Wade, I know you didn't approve it. I don't understand this. I don't understand this PTO thing, but whatever it is, it is. So we've got the OIG Coffee Table today. Wade McFall. By the way, I've now come to the conclusion that I am saying Wade McFall. I'm saying it correctly. I know that on the Long Island Library there was a discussion about it, and I came to this conclusion through the following. Number one, your last name is spelled F-A-U-L. If you had, if you were going to make Sunday sauce, S-A-U, sauce, fall, sauce, same thing. So I think that your ancestors,
Paul, the name Paul, P-A-U-L, it's Paul, not the way you might say it.
You can't even say it. You can't even say it.
I can't even say it.
Right, you can't say it. So, I mean, listen, whatever. We can agree to disagree. By the way, collaterally, I will say that I have suffered the same affliction because my last name is actually spelled Rubenstein, but it's pronounced Rubenstein. When people mispronounce it and they say to me, is it Rubenstein? And I say, no, it's Rubenstein. And they go, but it's spelled Rubenstein. And my response to them is, I'm just telling you what they told me when I was born. I don't make the rules. I'm just following them. So I'm just saying to you, it's McFall. You can say McFall. Tomato, tomato.
I can put you in touch with all my cousins and aunts and uncles who live in Manhattan and different parts of New York and Connecticut and ask them how to say it. They'll set you straight.
I don't they might try to set me straight. But again, they're going by what they were told. And that's that, and they're going back to the Midwest people and what they were told. So but anyway, it's good to have you. And there's and by the way, if you ask Matt Kachansky how his last name is actually supposed to be pronounced, he will actually say it's supposed to be pronounced Kohansky, which I don't even understand. The C is supposed to be silent. I mean, we're screwed. I mean, we're just screwed. And this is why I guess people say English is a difficult language to learn, but whatever it is, it is. Anyway, it's McFall for now and forever. And you can say whatever you want. It's wrong, but whatever. I'm not here to change your mind.
Yeah.
So today, so interesting, OIG published an analysis or a study that they did with CMS. So it was done with CMS, but it's really about CMS. But this was a unique one. They took a look at rehab claims. They did a statistically valid random sample, 200 claims. And it was a revisit of a study that was done a while ago. And I want to share it with everybody to see it. And the thing that I enjoyed, it just came out. Unclear Medicare requirements led to differing interpretations of inpatient rehab facility documentation, coverage, and billing requirements. And what I'm going to say, what I think is funny, unclear Medicare requirements. This is not novel. We have been seeing for years, instances in which regulation, policy, interpretations of such have been unclear, differing. We see instances with LCDs, local coverage determinations, which come from the Medicare administrative contractors, the MACs. We've seen instances where two different MACs will have a different LCD on the same CPT or HCPCS code. We'll see instances where a MAC will have an LCD, but another MAC will not have an LCD. We've seen instances in which the LCD gets updated and some of the language changes. So it is not a novel thing regarding clarity-related issues. And while I don't want to focus on our time at the OIG, we've talked about this, and I know we've talked about it with you and Matt, these instances where when we have found program weaknesses, we've alerted CMS to those program weaknesses, and some of those program weaknesses have to do ultimately with potentially lack of clarity on a policy or something along those lines. So this isn't a novel approach, but it did get me to it got me to thinking about instances when on the SIU side we're doing these investigations and you've got contracts in which the policies are not going to be followed, the same policies. We've seen instances where providers that are of the same specialty have different guidance that they're supposed to follow. We've seen instances where the organizational policy may differ from state regulation or federal regulation. And really, what it comes down to, Wade, is at the end of the day, you've got to do all that research before you start doing your investigation, meaning you have your data. What are the codes in question? Do you have a policy that's been revised? And I think, one of the things that we talked about was during the period of time when federal law was created to create the healthcare fraud statute, 18 USC 1347, and the conspiracy part of it, 18 USC 1349. Prior to that, we were using 18 USC 286 and 287, false claims. And there's instances where you've got a pattern of behavior that spans a time block in which the statute changes, or in the SIU space, there might be a policy revision. And so this really gets to the heart of, as an SIU investigator, once you've obtained your data and have gotten some basic information about what the allegation is, this is where knowing where to pull your policy, speaking to your payment integrity team, the auditors, these are those instances where I go to the auditors all the time and I say, get this for me. And I'll give you as my one example. I recently had a case that I was working on where there was a CPT code that had a really large non-coverage policy, but had a really narrow sliver of coverage. And it's a litigation issue in which the defense has an expert in which the question was posed, is this CPT code covered by Medicare? And the answer is yes, but nobody went beyond that. The code is covered, but it wasn't covered for the thing that the patient had. It was actually it's a non-covered service. And so those are one of those instances where I go to my auditors and I say, am I missing something in this? And I wasn't wrong in that instance, because the factual answer was yes, it is covered. It's technically correct answer, but it was practically wrong because of the thing that it was used for was a non-covered. It's considered experimental for some things, not experimental for others. But this is one of those instances, Wade, where getting that policy information and getting your auditors to help you with understanding, is there an overlap in the policy? Is there a change in the policy? Was the policy retired? What policy should you be looking for, particularly if you have a fraud that's a fraud allegation that has spanned past a period of time? Are we looking at the same policy? Are we looking at different policies? It's so I guess the take home is this study is not novel. Obviously, there are things in it that we want to talk about a little bit more, but it's not the study itself. When I read it, I wasn't like, this is an aha moment. This was like, it's a confirmation of what we understand, is that there's instances where there's confusion from providers on how and when to bill certain things.
Right. And in the SIU world, when you're bringing up a good point, if there's really confusion and there's not, that's not just like what they're trying to use as a defense where they're actually trying to steal money, it's a fraudulent situation. But when they really are confused, and that happens a lot because of the way the regs and the statutes are written, they're confusing, they're ambiguous. So when you come across something like that, there's a couple different ways to look at it from an SIU perspective, in my opinion. One is if you're looking at it to do a referral to law enforcement, either the Medicaid units or OIG, whatever. In that case, even if they are vague or ambiguous regs, you can still recoup an overpayment. You can try and get the money back, make the company whole, the government whole, whatever it is. But if it's the one thing that's missing in the referral or the more criminal or even civil is intent. And with these regs being so ambiguous, it's very hard to pull out intent out of something like that, unless of course you can get to the point where you have to dig deeper and you get into the investigation where you're getting emails where they're talking about how to use this ambiguity, there we go, as kind of a defense. But a lot of these times, especially in the SIU cases, the investigator has to look at it early on because they don't want to invest a lot of time into it and then later on find out that we have to close this. They don't like to do that because they're critiqued, their performance reviews, their evaluations are based on ROI, bringing cases to fruition. And if they start looking into something only later to find that it's the regs are just too ambiguous and too confusing, and they can't legitimately hold somebody to that because they're admittedly, even by the OIG and CMS, that they're a lot of times they're just too vague. So that should happen early, so you don't invest, months into it and then just have to throw your hands up and say we can't go anywhere with this case because the regs are just too vague.
Yeah, and the thing that I thought was interesting about this was a study that was done. The review was done between OIG and CMS, kind of in the collective, like they kind of joined forces for however they were doing this. And at the end, there were 4 recommendations that OIG made in an effort to reduce that ambiguity, which would in turn have the potential of reducing the error rate, which would then in turn have the potential of reducing overpayments, thus saving the Medicare program money. What I thought was interesting was that of the 4 recommendations, CMS disagreed with 3 and only said 1. Now, with a lot of these studies, we do find that when these studies are done by OIG, and people should always understand that when these studies are done, they're typically done as a work plan item or sometimes an add-on to the work plan. And they are done by OIG by either the Office of Audit Services or Office of Evaluation and Inspection. And the point of them is that OIGs generally are to be the watchdog for the programs that they work with. And the whole point of these studies is while the providers become the cannon fodder for the overpayments and that kind of stuff, these are ultimately commentary on how the program that OAS or OE&I are reviewing are being administered, right? So when OAS or OE&I do a study like this and they identify a program weakness, it's usually them going back and saying to CMS some derogatory things, right? I don't mean vulgar. I mean derogatory as in you guys aren't doing the right job. You're not policing yourselves properly. The MACs aren't doing this right. The UPICs aren't doing this right. CMS needs to do this. CMS needs that. There's a lot of finger pointing, right? And obviously CMS will provide its pushback because it is the program administrator and it's creating policies that they think are in line with how things are. What I found unique about this one was that they worked on this together and they still came up with recommendations, and CMS didn't agree with 3 of the 4 recommendations, which should have been kind of part and parcel to it. And it's not novel. We see this all the time. I know in the SIU space, we see all the time SIUs make recommendations to payment integrity, medical policy, whatever it may be, about ways to tighten up the programs, and they're not 100% always going to be taken into consideration. Now, there's going to be a whole host of reasons why a program is not going, why CMS is not going to agree with those 3 recommendations. Could be a million reasons. None of it is relevant for our discussion, but it just shows you that at the end of one of these reviews, there's always going to be those instances where there's going to be disagreement about how that policy was created, the implementation of the policy, or maybe it's that, hey, CMS comes back, the plan says, hey, we think our policy is good. Maybe we just need to provide better education, better training, or maybe the provider community is just trying to find their own ways to capitalize on that payment. But I think the takeaway for me is that when I see studies like this where it says the policy, there's ambiguity, there's inconsistency, we see that every day, right? We see it every day. One example that I know is out there is these instances of these impossible days where it's always, let's look at the worst case scenario for the provider and let's not take into consideration. We were just talking about this beforehand. For example, physical therapy one-on-one. If you look at the CPT code for one-on-one physical therapy, it's 15 minutes with provider. If you look at the CMS policy will say that a unit of physical therapy for one unit is something like 8 to 22 minutes.
Yeah.
Right? So the CPT code and the policy, not in alignment.
Yeah.
When an impossible day scenario is run, is the impossible day scenario taking into effect 8 minutes or 22 minutes? Right? One-on-one. Psychotherapy is very similar. A unit of psychotherapy in certain environments is a time range. Are you really in an impossible day? Are you not in an impossible day? And that's where sometimes your CPT code definition and your policy are not inherently aligned. And that's where I think, you've got to get your conversations going with that auditing team. I think, unfortunately, too many SIUs work in a siloed environment. And I think what we're learning as we grow our SIU teams is that siloed approach is becoming less and less attractive and becoming more and more challenging, particularly with data and AI and all of that. I mean, I know, we could never do our jobs in a siloed environment today. I think years ago it was a little different, but I think in today's world, having access with all of the things out there on the internet and coding tools and all of that, siloed environments don't exist anymore. And plans that are still working in a siloed environment are slowly becoming the dinosaurs of the payment integrity space. It really is no longer SIU payment integrity policy. It's really an overall approach, right? I mean, you work like that right now. We kind of work like that. It's just not successful to be siloed.
Yeah. I think a key point there that you brought up too is that, we have these data analytics and algorithms that pop things out like that, like a time codes that you have to really look at it, because you're not assuming it's the high end or the low end of that one unit, like you said, whether it's 8 minutes or 22 minutes. If you do that throughout an 8-hour day or generally a work day, it could be a big difference. So you can't just rely on a data dump and take it on its face and say, oh, this is like a fraud thing. You have to have an investigator look at it and rationalize it and look at what the other options might be. And again, the investigators, going back to, they don't want to have something that they've worked on for a while and say, oh no, it's fine, and explain it that all these one units were really time stamped and they were 8 minutes as opposed to the 22 minutes. So it's really not an impossible day. But the investigators, just like agents, you're supposed to be, non-biased finders of facts and taking all the facts into evidence and making your conclusion based on that, not just a data dump that says, oh, these, X amount of units per day equals more than, a work day. But if you look into it, maybe that's not the case because they're billing the low end of the unit. So it's not 22 minutes every time. Maybe it's 8 minutes. And if they have evidence of that, like time-stamped records or time-stamped things that shows that it's 8 hours and not 22, it's the investigator's duty to look at that and say, this is not fraud.
So that kind of gets to, as we kind of wrap up, it kind of gets to a good point, which is like SIU investigations should not inherently be a mechanical or a mechanically based process, meaning that when you have a code that has a range of time to it, you need to, first of all, you get your data, You've got to look at what the code says. You've got to look at the policy. That's the point where I would go to the auditor and I would say, hey, this provider is showing up in a report for an impossible day. What are the scenarios? And your auditor may come back and say, gee, this code allows a range of time. They may not be in an impossible day because if they're billing at the bottom end, which they're allowed to, you may not have this as a problem. And that's what an investigator needs to think from a provider abrasion perspective. Well, the policy allows, the code allows this range of time. Should I maybe ask for 5 or 10 records? Or should I just go full bore for the statistical sample of 100 or more records? Because maybe you look at 5 or 10 records, 15, some subset, a probe sample, and then you realize, hey, this is a false positive. The data is suggesting this, but the documentation is reflective of that. Right. That's where the rubber hits the road between someone who's going to be a successful investigator because they're moving cases quickly to a resolution, whether it's a resolution with an overpayment or it's an appropriate resolution to close the case quickly and move on. And that's where that payment integrity conversation occurs with your investigative team, understanding, hey, this code, there's a caveat here. This may not be an impossible day because of whatever it may be. And that's an important consideration that I think we don't spend enough time speaking to the auditing people about those things. We just look at it and we say, oh, impossible day, let's get 100 records.
Well, that goes back to yours and Jason's ongoing argument about does the data lie or does the data not lie? There's still not a definitive answer, but you have to interpret it. You can't rely on it on its face. I mean, you have to go in and you need a person to go in and look at the parameters and what the alternative outcomes could be. And so.
Right. And I mean, I'll say this, I've worked on a bunch of projects here with providers who were flagged for impossible days, like hospitalists. That one of the cases I worked on was a hospitalist case. And the allegation was that the hospitalist was working, more than a reasonable number of hours in a given day. And what happened was data was run and they just did a mechanical, okay, we're going to give this provider a credit of 12 hours. And after 12 hours, everything over that we're going to say is overbilled. And I went back and I said, hold on a minute. You're looking at a time period in which the CPT code for E&Ms in the hospital changed. It is no longer time-based as the goal. It's time or medical decision-making. You can't just look at the data and say, this provider billed for X number of people. The code says 15 minutes. Anything over this time period is, you can't do that anymore.
Right.
Because the medical decision-making is part of it. So for me, I say, that in that instance, I say the data's lying to you. The data's telling you that this person is working more than 24 hours, but the CPT code guidance has changed. It says medical decision-making or time. So you have to, you have to go and look at it. And that's where I think a strong investigator will say, hey, maybe I only request 10 records. I cut right to the chase. I spearhead my investigation time. I'm not incurring the time to an auditor for 100 records or more. I'm looking at a small subset and then making a determination there and then kind of taking it from there. So you're reducing provider abrasion. You are increasing ROI because you're closing cases that are dogs. You can hear it barking while you're looking at it. You just move on and kind of get to the next thing. But maybe it's not barking because you get your records and they go, hey, wait a minute. They didn't provide records. The provider doesn't even have them. The provider, is billing for a 50-minute, but the MDM, the medical decision-making, is showing that it's a lower level code. It's not the high level. There's some things that you can come out with, but you've got to do a little bit of that work to figure it out. So the moral of the story, I don't think we got too askew from the original intent, but the moral is that there is ambiguity oftentimes in policies. And auditors play a really significant role. I love using the term for our auditors here. I call them auditors because they really are. They're doing the audit, but they're supporting the investigation. and they have to be part of that. I don't think it was a shock when I read the analysis and I saw that OIG, that they did this study and found that there was ambiguity in a policy. Like, it kind of makes you go, of course there is. I was a little surprised at seeing that this was a study that was done in conjunction with CMS, and that CMS disputed some of the findings that they were supposed to be working with. But this happens. It happens. OIG, I remember when I started, my mentor Jason said, I know we've now mentioned him a couple times on this one, but he said to me that the biggest debates that will always come about when you do these cases always will be with CMS. OIG never wants to pay the money. CMS always wants to pay the money, and there's something in the middle that you have to work with. And oftentimes CMS um, has a mindset or a policy determination about how they interpret something, and it is their decision to do it. They're the payer, they're the one that makes that decision. OIG is oftentimes a rock and a hard place because they'll say this policy should be XYZ, and CMS won't agree because CMS has their own agenda on why they want that policy paid or how they feel that policy should be paid. And that's why I think in the SIU space, it's very important to be able to bring in those payment integrity people, those policy people, because maybe from the investigative perspective, we're seeing something and don't understand that full picture. We need to understand that full picture. So it's interesting. Yeah. Good stuff, Wade McFowle.
Yeah.
Well, listen, Matt missed this week. I think he's still out next week. We have a special guest, I think, for next week. We're going to talk about that with our special guest filling the role. We'll call it the OIG Roundtable, but we're really going to have like Knights of the Roundtable and the Queen of FWA. That's what I'll give to people. We'll get the national treasure, Queen teaser. Of FW, a little teaser. So as always, I appreciate you spending time with me. And for those that do our podcast every week, we appreciate you taking the time to listen. And we'll see you on the next OIG Roundtable. Take care, everybody.
Thank you.